Duke Majan, CEO and founder of Duke Spine Institute here in Florida. It is February 27th. Today we're going to be performing 3 Duke laser disc repair surgeries, all lumbar. And our first patient has 3 herniated discs in her lower back. We'll be doing a 3-level Duke laser disc repair. L34, L45, L5S1. Now she has pain in her lower back from L3 to S1. That's axial and paraxial. Axial means in the center. Paraxial means off to the side a little bit. And she has some weakness in her legs, but not horrible. So she has some radiculopathy as well due to stenosis. Stenosis just means narrowing. Spinal stenosis means narrowing of the spine. And we've talked a little bit about this in the past. These are educational broadcasts that you're watching. The purpose of the broadcast is to educate people, the public, physicians, nurses, healthcare providers, administrators, just the general public, basically, anybody that wants to listen in. All of our broadcasts are live from the surgery center, and they are free. They're broadcast around the world for educational purposes. All right, I'm going to talk to the patient, and we'll talk about stenosis. This is Dr. Duke Mage, and I'm here, okay? We're going to get started. I know Dr. Patel did his part. I'm going to get started with mine, okay? You just feel my hand pushing around a little bit. You're going to feel an injection with some medicine. That's numbing medicine. You might feel a little burning, okay? I apologize in advance for that. Just lay still. If you're having discomfort, just say ouch so we can hear you, okay? And then I'll know to give you some more numbing medicine. Any questions for me? 6 cc's injected. Any questions for me, ma'am? All right. If you have a question, you're welcome to ask me. I'm going to keep you awake for the very beginning, and then I'm going to put you to sleep, okay? But I need your help in the first 10-15 minutes, and then I can put you to sleep. Remember, just let me know if you feel pain. It seems to be a lot, and I'll give you some more medicine. Sean? I'm going to be talking to my team while I'm doing your surgery and talking to our audience as well who's watching. Most important thing I need you to do is, number 1, lay still, and number 2, tell me if you feel pain. All right, go lateral. Now your spine has got a lot of arthritis with bone spurs. That makes it harder to get to where I need to go. But you also have some twisting of the spine, and you have collapsed discs. So those 3 things just make it a little bit more challenging. Table needs to come down a little bit or fluoro up. All right, let's get 5-1. It's pretty good, but I think we need to wag it a little bit. It's pretty close. Sean? Let's see where we are. All right, so I think you're too far north. You need to be south a little bit. And I think you wagged the wrong way. I would go the opposite. I think you should be wagging the opposite way. So doing these surgeries, you need to really, first, before you really do very much, you need to get the spine lined up with the fluoro. The fluoro machine or x-ray machine is how we find our way. All right, release the wag. Shot. 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 That may be the best we can do. Will you lock the swivel and then release this so I can go up and down? Shot. I think that's better. Alright, go ahead and lock that in. I think that's better. So we're just getting the x-ray machine positioned properly so I can see what I'm doing, and then we're going to get going again, okay? Alright, you're doing great, by the way. Everything is fine. Just lay still for me, and that will be the biggest help. Shot. So, once again, folks, we use the x-ray machine, shot, to navigate, is the surgical term for it, which is basically to find your way down to where you need to operate. Shot. And at this point of the surgery, that's what I'm doing. I'm actually haven't started the laser surgery yet. I'm just navigating down to the spine to an area where I need to get to so I can do the surgery. Shot. Our patient is awake. She's helping me to get there. Shot. More on that later. Shot. But this is, in my opinion, the hardest part of the surgery. Shot. The navigation, which is what I'm doing now. Getting down to through the foramen. Shot. And into the disc. All right, I feel like we could wag it a little bit, just a little bit, to line things up a little bit better. I need about 1 or 2 degrees of wag, one way or the other, and I'll tell you if it was better or not. Go. I think that was better. I think that was better. Just to be sure, let's go the other way, and then we'll come back there if I still feel it's better. Yeah, I think that was better. Go back. So you have to be able to trust what you're using to navigate, okay? And the x-ray is very reliable. But you have to get it set as good as you can get it. Release the wag. I just shot. I think that's going to be probably the best we can do. Lock it. Are you comfortable? Huh? I couldn't hear her.
One more time, you're fine. She's fine.
Thank you. Shot. 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 That's where we are right there. I feel like we can do a little better this way. I'm not sure. Try a little bit further. Yeah, stop, and let's see what that does. No, other way. That's probably as good as we're gonna get it right there. Shot. It's a little bit higher than I want to be. Are you still comfortable?
Yeah.
Shot. Just a lot of bone spur. Yeah, I'm going to try again at a different angle. Shot. 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 Everything's going well. This part is the worst part of the surgery for the patient. And there's just no way around doing it this way. Shot. I apologize for any discomfort you may be feeling. Huh? All right, good. Just lay still. You're doing really good. Let's see here. Shot. Shot. It's higher than I want to be. Shot. Shot. All right, it's looking better. Let's get an AP. Any pain? All right. Are you comfortable? So let me focus on this for right now, folks, and then we'll talk in a little bit. But this is really, to me, the hardest part of the surgery. Yeah. Yeah. All right, we need to get a better AP. That's pretty bad. We need a better picture. Come on, Jordan. Let's go. All right. What's going on down low? I just think that we need to be more medial. All right. Let's see if I can get us more medial. Go ahead and go lateral again. Are you comfortable? All right. Shot. Should be facet. Let's get a shot and then go AP. Okay, that's facet. Let's go back to a lateral. Shot. 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 You're pulsing, right? Shot. Shot. That's not where I want to go. Shot. Let me have shot and then AP. And the lateral you still have? That's the lateral. So I'm more lateral than I want to be, but that's the facet joint forcing me lateral. The spine is rotated. Let's see if we can find the pedicle. That's the vertebral body there. Definitely some scoliosis. So we are really at the disc space. It's just so rotated between L5 and S1. It's quite interesting. Let's go back to a lateral view. See how rotated S1 is relative to L5? This is the worst area of your scoliosis we're dealing with right now. Are you comfortable? Still? Shot? And it's being deflected. Shot? Let's get an AP. See where we are. Huh. Yeah. So right now, we're trying to get into the left foramen at L5S1, and I'm going to have to try a different strategy. Let's go back to a lateral view. We're very close. They are too high. You feel that? Just pressure? Shot? Let's see if we can release this. And I don't want to wag it, but I want to try to level us out. Bring your side down. Let's see if that improves it. More. I feel like it's going maybe the opposite way of where I want it to. Try the other way. That seems better. Keep going. Yeah, it's definitely getting better. Let's go a little bit more. Maybe the very best we can get at this point. I wonder if we overshot it though. I think that's probably okay. Lock it down for a second. Alright. So having having yourself with the x-ray lined up properly is so important. Being able to try to do this procedure properly. Shot. If you're not lined up properly, you're not going to be able to navigate your needle to where you need to go. There's very little space to do the navigating. Shot. And in some patients, there's even less space because they have all these bone spurs from arthritis, and that kind of blocks your access to get in there and get it done. So I have to try different trajectories to see which one is going to allow me to gain access to the foramen. Shot? 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 All right. Shot? I like the trajectory here. It's coming a little bit more anterior. Shot, which is what you have to do when the patient has a lot of bone spurs. Are you comfortable?
Yes.
All right. Shot. Any pain? Shot. AP. AP. Are you having any pain? So I like to check with the patient to make sure they're not having any unusual pain that I don't want them to have. That's the reason why they're awake, is to kind of help guide me to where I need to be. Shot. Are you having any discomfort? Shot. Lateral. Lateral. We're definitely closer now than we were earlier. You can see I had to change my trajectory a few times in my entry point. So, just a little bit off of where we need to be. Shot. Uh-huh. Shot. 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 Anything? Shot. Just pressure, okay. Nothing down the leg? Good. Shot. AP. Yeah. That's about as good as you can get with this collapsed disc and arthritis. Go back to a lateral. You're doing good, by the way. You're just not making it easy for me. But the hardest one, we're pretty darn close to where we need to be, so. All right, we're just dancing. All right, let's go ahead and make an incision. So ideally, we want to be inside the disc. And let me know if you feel any discomfort, okay? And the fact of the matter is that sometimes, and I've learned over experience of doing these, you can't always get what you want in terms of positioning of the needle to start the Duke laser disc repair. I need you to get 4 or 5 lined up properly. So I'm about as close as I can get. There's apparently a lot of bone spurs back here in the back of the disc, so it's blocking the needle's access to the disc, and I cannot get it to go through. So I'm going to go ahead and just stop there, and then I'm going to come back when she's asleep and she's more relaxed, and then I can maybe get it in. All right, okay, so what are you doing, Jordan? Okay, what are we doing next? Okay, this is, you need to make an improvement in how your technique. Okay, where is 4-5? Say, where do we want it? We want it in the center of the field. That's like basic 101 radiology technician. Can you lower the fluoro to the ground? Then you tell the table to come up a 1/4 inch. Good. Okay. You're still off, aren't you, on your pedicles? Are you able to see that? It's not much. You're only a few degrees off on your WAG. I think you went the wrong way. Try the other way. Bring the table up 1/4 inch. No, whatever you did, it's worse, so go back the other way. That's pretty good. I think we can do a little bit better. I'd say maybe try a little bit more. You're almost there. You're about a degree off. I think that's probably as good as we're going to get it. I think that's fine. Let's just leave it there for now. The table is too high. Drop it just a 1/4 inch to a 1/2 inch. All right. Are you comfortable, dear?
Yeah.
All right, just lay still. Everything's going good. I knew you weren't going to be an easy one, so it's just taking us a little longer than normal, but I'm not concerned at this point. We're just chugging away, okay? Shot. 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 Any discomfort?
No, I could feel it.
Where?
It seemed to be in the middle of my right hip.
Uh-huh. Well, that's okay. You're doing really good. We're actually not in your hip at all. We're in your back, but there's referred pain. Shot. If I'm anywhere near your hip, I'm in the wrong place. I'm outside my specialty. Are you feeling any discomfort right now?
No.
Good. Shot. Well, we're right there. Give me an AP. Yeah, that's good. All right. Lateral. So for those of you watching, this is like a level 10 case, as in the hardest, because of various factors, but one of them being the position of the disc. how collapsed it is. And how twisted the spine is from scoliosis. Shot. Now, we're not here to fix scoliosis. I don't think that is necessary in her case. We're here basically to treat the stenosis and the back pain that she's having. And we can do that without doing a fusion and screws and rods usually. But I think we're definitely in a good position to do the surgery, but I'm not going to be able to do a discogram, unfortunately, which I wanted to do. Are you still comfortable? All right. Well, we're getting close to being done where we can put you to sleep. That looks good, Jordan. I think that's about as good as we're going to get it right there. We've got 2 of our probes where they need to be, and the 3rd one is on its way. Shot. And then once I get everything where I need it, then I can put you to sleep. Shot. Okay, you looking forward to that? Shot? I bet you are. Shot. Any discomfort? Shot. Anything? Nothing down your leg? Shot. All right, AP. It's looking good. Lateral. It's nice and wide open. On this side, it's wider open, the disc on the right side that we're on, than it is on the opposite because of scoliosis. Hopefully we'll be able to get into this one at least. All right. Remember, she's rotated, so you have to account for that when you're reconstructing in your mind everything. Any discomfort there? Huh? Pressure in your back? Shot. I think we need to be a little bit higher. Shot. 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 Yeah. Shot. Shot. Where do you feel that? Shot? In your back? Not down your leg? Shot? Alright. So we should be in posteriorly. Are you comfortable? Where do you feel that? Is that your typical back pain? Is that where you get your back pain? On a scale of 1 to 10, how bad was that at its worst? 8. So L3-4 is an 8 over 10. I don't think I can do the discogram at the other levels because I'm not in far enough with the needle yet. I'm going to try at L4-5, but 5-1 for sure I'm not. But I may be enough on 4-5. So I'm going to try 4-5. But I don't think we're not going to be able to do 5-1s. I'll just say unable to perform. We'll try this one. I doubt it's going to work, but we'll see. Shot. Oh, good. It's working. How bad is that on a scale of 1 to 10? 8, 9? So 9 out of 10. Is that where you typically get your pain? Yeah. So yes. All right. Well, the good news is you get to go to sleep now. You've done your job of helping me, and I appreciate it, and I'm sorry you had to go through that, but everybody does. Nothing unusual for you. Did you know you have blue blood? I'm kidding. All right. Well, when you wake up, we'll be done, and you get to recover from your surgery, okay? Sweet dreams. Go ahead and count from 1 to 100 out loud. So while she's counting, we're going to put her to sleep. You'll feel a little burning in your arm. That's just the medicine going in to put you to sleep. So spinal stenosis just means narrowing of the spine. And there's really 3 places the spine gets narrowed: central, lateral recess, foramen. Those are the 3 zones or areas of the spine that we break the spine up into, and we characterize stenosis in each zone based on how much narrowing there is. So the most common place to get narrowing that causes symptoms of pinched nerves, either in your neck down your arm or in your back down your leg, is the foramen, the neuroforamen. The second most common, which is just about equal to it, is the lateral recess. The lateral recess. So central stenosis, or narrowing of the middle of the spine, causes symptoms in the leg less than 1% of the time. So for all patients with pinched nerves in their back or their neck that have symptoms going down into their leg, less than 1% of them will have central stenosis as the cause. Less than 1% of those patients with symptomatic radiculopathy, that means symptoms down their leg from a pinched nerve, less than 1% have central stenosis. Yet radiologists, for the most part, most radiologists, all they look for is central stenosis. So by only looking for central stenosis, they're going to miss the actual cause of stenosis 99% of the time. Now, of course, radiologists don't realize that. I'm going to start with these. Shot. Are you okay? All right, so she's dozing off to sleep at this point. We're going to allow her to get some rest, and we're going to do her surgery while she's in twilight anesthesia. Twilight anesthesia just means that the patient doesn't have a tube down their throat and that they're not completely asleep. So they're like sleepy sleep, but not where their brain stems aren't working. So the distinction is general anesthesia versus sedation. And the truth is that most patients that have the surgery and that have propofol, they're all having general anesthesia at some point during the procedure where they're completely out and they're not consciously aware of what's going on. And remember, the more pain we create, the deeper the patient needs to be. And so right now I'm stimulating her and causing some pain, and she's wiggling a little bit. And I don't mind a little bit, but we want to probably get her a little bit deeper. Shot. Everything's okay, just lay still. I mean, you're welcome to give a little bit of fentanyl too to help with the pain. So you don't have to put her so much propofol. Shot. 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 We're getting down to the annulus, and she's doing fine, folks. Shot. And I'm just slowly bringing this thing in. We're right at the back of the disc. As a matter of fact, I can feel the herniation, and I'm pushing the herniation into her disc, which is nice. It's one of the nice things about this technique is that by using the dilator down the guide wire, we're actually pushing the herniation. Shot. Let's go, Jordan. It's just not been my week for guide wires, has it? Shot. All right. So the more relaxed the patient is, the less pain the patient's in right now, the easier it is for me to do the surgery, because a patient who's experiencing pain is going to tighten up their back muscles. And when they tighten up their back muscles, well, sure, they're going to move a little bit. I don't mind a moving target. I know that sounds cruel, but the truth is that the patients are going to be amnestic to the event, which means they're not going to remember it. So our anesthesiologist has really several jobs over there, and everyone thinks light sedation like propofol sedation is safer than general anesthesia with a tube down, but it's not. Wouldn't you agree? Yeah, what our anesthesiologist does right now during this surgery, by not having a secure airway, is the most risky type of anesthesia, but it's the right type of anesthesia for the patient. Because by putting a tube down, you have all the issues that patients get from having a tube down, okay? But not having a tube down makes the anesthesiologist have to work harder and make sure the patient is stable and safe and breathing, and that their airway is open and they're not obstructing. And that's what a tube gives you. The tube down the throat, down the trachea, allows the anesthesiologist to not worry about obstructing. All right, but then they got to worry about other things with the tube, like the tube moving or coming out, or the cuff deflating and then not ventilating properly. But I still think twilight anesthesia, most people want it. They're like, oh yeah, twilight's great, it's safer, but it's actually probably not safer. I think it's harder for the anesthesiologist to do twilight than it is general with the tube down. But we need the patients to be awake in the beginning, so we don't have a choice. The propofol sedation in the vein with MAC is the right way to go for this type of surgery. And at Duke Spine Institute, I have a choice. I could A, do the sedation myself, B, hire a nurse anesthetist, or C, hire an anesthesiologist, or D, don't do any sedation at all. So of those four options, the very best for the patient is an anesthesiologist. Because an anesthesiologist, in my opinion, and I know I probably draw criticism for saying this, but it's pretty crazy what we live in these days. But an anesthesiologist is better, in my opinion, than a nurse anesthetist, okay? And those are your two best choices. The surgeon himself or herself doing the anesthesia is a very bad idea, because I'm focused on doing the surgery. I don't want to be worrying about administering a sedative to the patient and obstructing their airway. That's the riskiest of all the options. That's the one we don't want to do. I mean, even giving no sedation at all would be safer. And that's why it is an option, but that's not an option that I would choose for my patients, because it's too painful. And I don't want them experiencing that pain. So of all the options, the anesthesiologist being here to do the case is the best. Okay? The safest for the patient, the best for the patient. But a lot of places cut corners, and when they do twilight, they don't have an anesthesiologist do it. They have somebody else do it, either the surgeon or the nurse. And again, in my opinion, and I'm telling you this because I truly believe it, for what it's worth, the anesthesiologist is the safest for the patient, the best for the patient. They're also the most expensive, okay? I don't turn the suction on the tube on. Luis, you know that, right?
No, I'm talking about my
Standby. So we're inside the disc, and on the left there at 9 o'clock is the end plate of L4. And the herniation is right here. We've been zapping it a little bit with the laser. The annular tear is at 12 o'clock. We're going to get to that. I'm just trying to get rid of some of these chunks of herniation. Now, some of you may be saying, well, if they're herniation, why are they inside the disc? Well, that's exactly a great question. Do you remember we pushed that tube in, right? Through the foramen. What? So when we pushed the tube in through the herniation, we actually went through the herniation to get the tube in. That's one of the beauties of this technique, this Duke laser disc repair. And it's something that I took from Dr. Anthony Young. Dr. Young taught me what's called the inside-out technique, which is a safer technique and a better technique, but it also allows the surgeon to push the actual foraminal herniation, much of it, from the foramen into the disc during the exposure, during the approach. So this is the annular tear. This blue thing is the laser fiber, in case you didn't know. And the thing about Duke laser disc repair is it really is laser spine surgery. The old Laser Spine Institute that went bankrupt last year, and most other surgeons that do this type of surgery, they don't actually use the laser. They just use it as a marketing tool, but they don't really use the laser because they don't know how to properly use the laser. Lasers are actually expensive. And so I know that at Laser Spine Institute they used to advertise laser spine surgery, but they actually never used the laser. I know this because there's a variety of reasons, but number one, I know surgeons that work there and I know what they did and didn't do. Number two, I've defended Laser Spine Institute in lawsuits as an expert on their side, protecting them. Of course, that's only when they deserve to be protected, when they didn't do something wrong. So, fact of the matter is, the laser is an extremely valuable tool in medicine. And by the way, this stuff right here you're seeing was pushed in from the where the nerve was. So by putting that dilator through the tear and the herniation, I actually shoved the herniation back into the disc, and that's what I'm zapping away right now. That right there. You can see how collagenized and calcified it is. It's golden color. That's a dead giveaway of the calcium from calcification. And it's very scarred in as well. How are we doing, Luis? Good job. I think having that thing around my wrist is going to be helpful to you. Okay? You should be making a point to do it. That's where all your water on the floor comes from. All right, she's moving a little bit. She's a little too light. Starting to get there. Questions from our audience. Why is there something on top of my foot? I feel like an armadillo just sat on my toe.
Nothing yet, Doc.
What's that?
No questions yet.
No questions yet. Is that Sonny?
That is.
Sonny.
Hey.
How are you, buddy?
Hanging out here in the chat.
All right. Well, if there's no questions, I guess I'll just keep talking or I'll start whistling Dixie. So for those of you watching this broadcast, this is live spine surgery. If you're watching on February 27, 2020, I'm Dr. Ara Duke-Majan, the CEO and founder of Duke Spine Institute. I've been performing this surgery now for 13 years, actually 14 years now, and in 14 years we've had incredible success with the surgery. We've been able to eliminate 95% on average of the back pain or neck pain if you have it done for neck pain and you have a herniated disc in your neck. The surgery really is designed to treat herniated discs, degenerated discs, spinal stenosis, pinched nerves, irritated nerves. Some people have a herniated disc in their neck where they get neck pain and headaches. The headaches come from the neck and they shoot up over their head. Those are called cervicogenic headaches. They come from a herniated disc. The patients that have Duke laser disc repair for a herniated disc in their neck have about 95% relief of their headaches after surgery. This is the only surgery that's been proven to eliminate headaches that come from the neck, from a herniated disc. Okay? There's no other surgery in the world ever published to relieve headache from a herniated disc. Duke laser disc repair has been peer-reviewed and published years ago in 2012, 2013. It is not an experimental surgery, though the insurance companies like to call everything experimental these days so they don't have to pay for it. That's their only out, by the way. So as long as we let them call procedures or tests experimental, they're going to continue to be able to deny it, not pay for it, which is the end goal for them. They don't want to pay for your medical care. The more medical care they pay for, the less profit they make. And they're very, very good at making profit, by the way. My anesthesiologist here is listening to me and probably thinking, yeah, you're right. You know what Medicare pays for an anesthesiologist per hour? Any idea?
Medicaid or Medicare?
Medicare.
Maybe $60.
Huh?
Maybe 60.
So the patient has a copay of 20%, but Medicare pays about $90 an hour for an anesthesiologist. Would you work for $90 an hour? No. No anesthesiologist I know of works for $90 an hour. They all want $200 an hour, maybe more, and they deserve it, to be honest with you. They 100% deserve the money that they're getting, and they actually deserve more. But Medicare will only pay $90, less than $100 an hour. She's moving. So why is that? How could Medicare pay less than the going rate? I'm going to tell you why. Because Medicare is run by the commercial insurance companies. And what they've learned is that if they set the rates low with Medicare, the federal government, then they get to piggyback on those rates, and they get to set their rates low. They just say, hey, we pay the same as Medicare. Well, the thing that people don't understand is that they're the ones setting the Medicare rate, because they're the Medicare administrating companies, or called MACs. So Blue Cross Blue Shield is a MAC. They control most of the western and middle of the United States. And Blue Cross Blue Shield basically does all the claim processing for Medicare, all the benefits for Medicare patients. So if you're a Medicare patient in California or in the Midwest, Blue Cross Blue Shield is your Medicare administrator. Now, they don't call themselves Blue Cross Blue Shield. They have schmancy names. For example, in Florida, Blue Cross Blue Shield is the Medicare administrator. They call themselves First Coast Services. You've probably heard of them if you live in Florida. First Coast Services. So everybody thinks First Coast Services is Medicare, which it is, but it's actually Blue Cross Blue Shield subsidiary. So it's controlled and owned by Blue Cross Blue Shield. Well, First Coast Services gets to choose what procedures they're going to cover for Medicare beneficiaries. They can deny whatever they want, basically. And they can set the rates that they pay hospitals and doctors. And that's exactly what they do. They keep lowering the reimbursements every single year. I make right now for my surgeries, for example, as a top neurosurgeon in the country, I make 50% of what I made when I started 16 years ago. Half of what I make. And that's because of declining reimbursement by the insurance companies and Medicare. So these Medicare administrators like Blue Cross lower the rates of what they pay hospitals and doctors through Medicare so that they can pay less and say, hey, we just follow Medicare. It's basically a scam. But it's a scam they've been getting away with for the last 15, 20 years. Nobody stopped them, mostly because nobody knows they're doing it. All right? How many people actually knew First Coast Services was Medicare? The other Medicare administrators in the United States include United Healthcare, Humana, Cigna, and Aetna. Those are the main insurance companies that run our country. And they do run our country. They make the laws, whatever laws they want to make. So just so you understand, there's something called lobbying that goes on in Washington, D.C. And I'll give you an example. I've talked about this before. Since you guys aren't asking questions, I'm just talking, okay? But this is part of the education. Lobbying is basically a big business in Washington, D.C. It's where lobbyists who are not elected, they're basically hired by private companies like the health insurers. They go and meet with our congressmen and senators on a routine basis, and they tell them what to vote on certain laws. And they've been doing that for the last 50, 100 years. So there's nothing illegal about lobbying. However, when your politicians just blindly listen and don't do their own thinking or investigating, then of course the lobbyists can have tremendous influence on our politicians and our laws that are made in this country. So, would you be surprised to know that fact number one, smoking cigarettes is a major cause of disease in the United States. It is a major cause of death of people, healthy people that would normally be healthy, die from smoking-related illness. Okay, why is tobacco still legal in the United States if we know its harmful effects on people? The reason is lobbying. Lobbying, lobbying, lobbying. The tobacco industry spends $50 million a year lobbying in Washington, D.C. 50 million. That's a lot of money for most of us, including myself, but not the insurance companies. For $50 million a year, folks, you could go and lobby in Washington, D.C. She's moving too much. And you get to kill people legally. All right? So, how much does the health insurance industry spend every year in Washington, D.C. lobbying? Would it surprise you that they spend more than the tobacco industry that legally kills people, millions of people, and makes them sick as hell? Guess who pays for all those smoking-related illnesses? When smokers show up at the hospital and they don't have insurance and they have an emphysema or a COPD exacerbation, you pay for it, the taxpayers. The insurance companies don't pay for it. So, for $50 million a year, the tobacco industry legally kills Americans, and that hasn't stopped, even though we know tobacco causes death and serious illness. What do you think the health insurance companies spend every year? 10 times that. $500 million a year in lobbying. Why would the health insurance companies need to lobby? I mean, after all, they just sell an insurance plan, right? They go to your work, they talk to your HR department, and they sell insurance. Why would they even need to lobby in Washington, D.C.? Any ideas, folks? I'll tell you why. Because they're killing you with their policies. That's why. And they need the backing of the politicians and the laws. They need laws to be written that allow them to deny care. That's why. And that's exactly what they've done. They've gone to Washington and they've written laws that say, hey, if we think treatment is experimental, if treatment is experimental, we should be able to deny paying for it. And you know what your politician said? Yep. I agree with you. So they wrote laws that says experimental treatments and tests in medicine don't have to be paid for. And then they take the next step, which is, well, we get to decide what's experimental. All right. That's like a rapist saying, I'm going to decide what's illegal, whether rape is illegal or not, and I'm going to decide what constitutes rape. Okay, would you allow a rapist to decide what the definition of rape is? Would you allow a rapist to just rape people without stopping them from violating people? The insurance companies are violating all of you every single day. Every time they deny something your doctor orders, the hospital orders, they are raping the American public. And they keep raising their rates every year. Why do they keep raising their rates, by the way? You ever think about that one? You think they're paying doctors more every year? Maybe they're paying the hospitals more? I got news for you. They're not. Actually, hospitals are going bankrupt. We've lost 300 hospitals last year. They all closed from bankruptcy. Why? Underpayment by the insurance company. Unprecedented, historically low payments. The insurance companies are denying more than ever before. So if they're not paying the doctors and they're not paying the hospitals, who are they paying? Anybody know the answer? They're paying themselves. That's exactly right. Their profits have gone through the roof in the last 5 years with the amount of denials they're doing. Meanwhile, doctors and hospitals and chiropractors and physical therapists are going out of business because they can't get enough money for the work that they're doing. But that suits the insurance companies just fine. After all, access to care is a wonderful thing if it's restricted. If you're an insurance company, if your patients that you are paying you benefit money, premiums every month, if they can't find a doctor or hospital because they're all closed down, that means they can't get medical care. That means you're going to make more money that year if you're an insurance company. So I talk about these things every week, and yet it's amazing how little people actually know about it, and how little they actually seem to care. So why do I keep talking about it if people don't care? Either I'm stupid, or I'm hoping one day people will wake up and, what is it called? Smell the coffee? After all, it's their health. So these live surgeries are for education, okay? Is she okay? A little coughing or something?
Just got some reading.
Okay.
We have a couple questions.
Oh, people have questions now. I thought you guys knew everything. Yes, of course. She's moving around a little. I'll take the question.
We have one viewer who says that they have ankylosing spondylitis and they're
Yep.
terrified to have surgery that has been recommended to straighten their back. What is your opinion on that surgery?
So we have a patient with ankylosing spondylitis, which is an inherited disorder that is genetic, and it causes the spine to fuse itself. And it becomes very stiff and painful. And they want to know if they should have spine surgery. Well, first of all, I'd like to know why you would have spine surgery. There's no reason for an ankylosing spondylitis patient to have spine surgery unless you have a fracture. Do you have a fracture? Did you fall and hurt yourself? If you've had a fracture of your spine after a fall, then you definitely need surgery. Otherwise, you're gonna end up paralyzed. So I'm not sure what your circumstances are, but generally ankylosing spondylitis is not a surgically fixable condition. It's not something that a spine surgeon can fix. It's only fixable when you fracture your spine. And ankylosing spondylitis patients will come in after a fracture, after a car accident, and they'll come into the hospital and they'll say, yeah, normally my neck is very stiff, but after that accident I can move it better. There's some pain, but I can still move my neck better. Well, that's bad. That means you have a fracture in your ankylosed spine. If you were fused before, auto-fused, and now you can move your neck. So that definitely needs surgery. What kind of surgery are you contemplating? Just about done with this disc.
While we wait for that viewer to get back to us, we do have another question.
I couldn't hear. You got to give her a little bit more pain medication or propofol. I can't have her moving around like that. What is the comment, Sean?
We have a separate question while we wait for the first viewer to get back to us with those answers.
Sure.
The other question says that the viewer has been diagnosed with spondylosis and degenerative discs and is wondering if we treat pain caused from them.
If we treat what? Spondylosis or degenerative disc?
Yes.
Our irrigation is low, guys? We do. Spondylosis basically means a collapsing of the disc with the formation of a herniation and bone spurs. So basically it's exactly what this patient here has. She's got it really bad, so we can treat spondylosis definitely. And then the other conditions you said she had? I apologize. Just spondylosis? So we can treat spondylosis, stenosis, radiculopathy, herniation, bulging disc, collapsed disc, anything that causes pain and suffering can be treated with the laser surgery, even spondylolisthesis. This patient has scoliosis, and yet we're still doing her surgery, right? We're not fusing her spine. We're not putting in screws and rods. We're able to fix the pain without actually fixing the scoliosis. What does that tell you, folks? It tells you that scoliosis is not the cause of the pain. I'm not fixing her scoliosis, yet we'll take her back pain away most likely. All right, I'm just about done with this here disc. She had a big tear. Those are fibers of the posterior longitudinal ligament up there. I feel pretty good about it. How is she doing? Do you have, what was the other question? Did I answer it all, or do you have something else you want me to answer? Sean? Sean, I can't hear you.
There are no other comments or questions for
All
now.
right, well then just say that, okay? Don't let me sit here and talk to myself. What's going on? Huh? Everything okay?
Yep, take a deep breath.
She okay? All right. Laser off.
All right, lights on, please. Laser stand by.
And we're done with this disc. Yep. Thank you. All right, so one disc down. Got two more to go. Come on in. Bring that down here. Why are we just leaking everywhere? I don't understand. Luis, why are we leaking everywhere? Why is water getting all over the floor?
Well, I don't know if it's on the corners. I can.
Yeah, but you got to figure it out. We don't need to keep it in the bag. What could you do with the gray cord?
The record, just maintain it inside the bag.
I can't. I mean, it's moving. What could you do with it? How do you direct the water from my hand into the bag?
Do you think I should do the same?
What could you do?
I should do the same. Put a brake tape on the.
Yeah, it's obvious. I wouldn't do a Raytech. I'd do something bigger, but something to direct the water so it's not dripping on the floor. It's going in the bag. So you put a towel around the cord. It's really not brain surgery, guys. Come on. How we doing there? Do you do a lot of propofol stuff normally, or not so much? All right, me too. I do a lot. Not on the anesthesia side. Shot. I would recommend talking to a guy that worked with me for about a year when you get a chance. I would recommend talking to an anesthesiologist that worked with me for about a year, Dr. Santiago. He had figured everything out by the time he left. Shot? He probably could give you some good pointers. Just, huh? I don't know what he did. He did something, but he never had any issues. I think what he figured out was like when the patient's going to have pain. You know what I mean? Like going through the annulus, and then once I start coming back with the scope and the laser, that's when we're hitting those pain fibers again. So he kind of knew when to maybe give some fentanyl. I think he gave fentanyl, but I just don't know what he did exactly. But I mean, the patient's like literally cruised.
I got a strong feeling I know what he was doing.
But you could look at his anesthesia records, or you could call him and talk to him. He's a very nice guy. He was our fellow that you're considering as well, but he was our fellow for a whole year. So he did surgery with me for an entire year.
Swan?
Huh?
Juan Santiago?
Yeah. Santiago. Now you don't want to talk to Dr. Santoro, on the other hand. All right, that's where we are? All right. Santoro was a complete goof-off. Shot. I mean, that guy, if you want to talk to him, you do exactly the opposite of what he says. We had to fire him. We've had some interesting people. Yeah, this is the more painful part. I really think you should look at it or talk to him, because he had strategies that he developed that were very effective. Is she okay? She's about to get stimulated. Shot, huh? All right. All right, let me see what I got here. Shot. I need to point down a little bit. Shot. Yeah. Now, Louise, take this. Come on, I need your help. Shot. Shot. Good. Shot. Perfect. When they're relaxed like that, I can actually get the dilator in nicely and easily and safely. So that was really good. The 5-1 is going to be the challenge. There's no doubt about it. Lay still. Do you have his phone number? Shot. Shot. All right, so we've just placed the dilator and the tube into the second disc that we're going to be fixing today. Shot, and that is the L45. We've already done 3-4. Let him get the fluoro out. Let me go. Let me have it. right. So let's head in and see what we've got. So we're inside the 4-5 disc at this point. You can see all the arthritis on the end plate there. A little bit of blood clot, no big deal. Really not much disc left here. Okay, so is that a problem? No, it's not a problem. What are we after? She's moving a little bit too much. What we're after is we want to repair the annular tear. Okay, the annular tear is the source of the back pain when it comes from a disc. Nothing else but the annular tear. If you can fix the annular tear, then you'll take away their back pain or their neck pain. When I say they, I mean the patients, obviously, that have back and neck pain that come to you. So that's what we have to do. We have to debride the annular tear. Now, I know it's not good visibility for all of you, but I know what I'm doing. I've done it literally thousands of times. So I know exactly what I'm looking at, and this is the annular tear up here at 12 o'clock. There may not be any nucleus left in this disc, but there will be an annular tear if it's painful. And this patient has pain from this disc. We tested it on the discogram, definitely painful. So I'm confident that there's an annular tear. Plus I could see it on the MRI. The whole disc may be completely collapsed, all the nuclear material gone, bone on bone, but there's still an annular tear. And there's still an annulus that needs to be debrided. Okay? And it's always in the back, posteriorly. Again, I apologize for the poor visibility. We have a little fumarole here. Small little epidural vein that's just oozing. A little bit of fat. But this is the annular tear right here. Now, the Duke laser disc repair, for those of you watching, is the only surgery in the world that repairs the annular tear. All other spine surgeries don't address it. And that's why most spine surgery doesn't fix back pain, is because the spine surgery doesn't address the annular tear. Now you can do a fusion and clean out the annular tear while you're doing the fusion. As long as you do it right, you can actually stop people's back pain and neck pain with a fusion. As long as you stop the movement at the painful joint, you can or eliminate the annular tear while you're in there. For some reason I'm having trouble getting to 12 o'clock. Why is that? And what it is about the annular tear, folks, is there's actually a sack of little nerves in there. And they get there from the chronic inflammation at that disc. So that the tear happens, and then the nuclear material comes out. That's the herniation. And then once the nuclear material comes out, that nuclear material irritates the annular tear, causes inflammation, chronic inflammation. Meanwhile, the annular tear is trying to heal it, but it just can't, because the nucleus pulposus is wedged inside the annular tear, blocking it. Yes, what is it? Everything okay, guys? Huh? Yeah. Yeah, it is. It's been that way since the beginning. What about it? For some reason, we're not getting the flow down there with the irrigation. Oh yeah, yeah. We don't want to pop the bag. Just about done with this one here. Not much left to do here. And then, huh? Yeah. Huh? What?
I have a PTSD, she says close.
I can't. PTSD. Oh yeah. From the last explosion. I agree. We all do. Sure you didn't. All right, we're pretty much done here. Again, I mentioned it to you guys the last time, but the collapse discs, they're harder to get into, but you don't have to spend as much time on them. Scope off, because there's not much disc there to take out. So it's a trade-off, you know, with the collapse disc, that when you treat them with the laser surgery, you don't spend as much time treating them because they don't have as much herniation, because there's not much disc there to herniate. It's already degenerated and gone. Luis. On the other hand, it takes longer to get in. So your surgery time doesn't change much. Maybe it gets longer because it's harder to get your needle in place. But the amount of time you save on removing the disc herniation, the soft nuclear material, and a normal disc that has a tear and a herniation, that time is probably not as much as it takes extra time to actually get into the disc in the beginning. You saw how long it took us in the beginning just to access the disc, L5S1 being the most difficult. Come out or take a shot. Shot. All right, we need to line up 5-1. It's pretty close. I think we need to wag it just a little bit to get those pedicles lined up a little bit better. Why is our picture so grainy? Shot. I don't know. Do we get better or worse there? I think you got worse. Go the other way. Shot. That's better. I think that's better. All right. Hold this here, Luis. What is that? Guide wire. You've gotten quite good at straightening these things out, haven't you?
Oh my gosh, yes.
Well, remember, if they're bent badly, don't use them. Okay?
Well, the thing is, it's 10 for 400 bucks.
What?
10 for 400 bucks.
That's ridiculous. Why don't you find another one? Where do you get them from? Wolf?
Yeah.
No, there's somebody else. You need to look. Shot. Huh, great.
I do my best.
Shot. Do we move the fluoro? Shot. Oh, this thing. Shot. After I remove the blue towel? Somehow we moved, I think. Stay where you are. Yeah, these are just guide wires, Luis. They should be, look for them on Amazon.
Yeah.
We don't need to be paying exorbitant prices for them. $40 for a little strip of metal is ridiculous. It's just price gouging. And we have to pass that on to our patients, you know. That's obscene. Shot. Shot. Everyone wants to know, why is healthcare so expensive? So it's expensive for patients because your insurance doesn't pay when they should. That's 90% of the reason. But the fact of the matter is, like this little piece of wire metal that I'm using, the guide, believe it or not, that's $40. I just found out. $40 for one little wire. It's ridiculous. It's no different than any other wire. And the problem is that these companies that develop this stuff, they think that they have a right to charge people obscene amounts of money, and they don't. So the nice thing is, over the years, competition rolls in, and somebody else will produce this same wire for $2 a wire. Shot? All right, so we're making our way down to the L5S1 disc. No. And this is the one that I had the hardest time because of the bone spurs. Shot? Yeah, the bone spurs are trying to force the dilator into a place I don't want to go. And I can only do so much to redirect against the bone spurs. Shot? There, that's pretty good. Shot? I just need to get it down against the disc, and then we'll be able to. She's moving too much. Watch that. Lay still, everything's okay. Getting close. Shot. That's pretty good. I really need her more relaxed. Let me know when I can proceed. Is the next patient here? Uh-huh. All right, take this. It's pretty good. Let me have the hammer. Shot. Shot. Not really happy with that. Shot. Yeah, she's just moving around a little too much. Shot. Shot. How's she doing? Shot. Let's get an AP. Shot. Lateral. We're right there. If we can just make it happen. I can't see. Yeah. Man. Shot. 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 Yep. Pressure. Well, we couldn't do everything I wanted to do at 5-1, unfortunately. But I think we're gonna have a great result. So hold this pressure here. Hold the pressure there. All right, so we're done. Let me show you the incision so you all can see. We did the entire surgery through a tube, a metal tube. It's called the tubular retractor. Can you see that, Sean?
Yes, we can.
All right, and you can see it's about the diameter and size of a straw. And to get that in, we had to use, would you move that out of the way, please? Use your head. To get it in, we had to use a dilator. So you can see the tip is tapered, and that spreads the tissues open. And then over that, we put the tubular retractor. And we do the surgery through that tube. All right, I'm going to head over to the conference room and I'll answer any questions you all may have. Again, I'm Dr. Duke Majan. You just watched Duke Laser Disc Repair. Patient with herniated discs, back pain, and leg weakness, numbness, pain. Actually on both sides, but worse on the left. She wanted her left side treated. Hopefully we won't have to come back and do the right side, but she did have some symptoms on the right side, just not as bad. Sorry, we did the right side. She has symptoms on the left side. I apologize, and hopefully they're just not as bad, so hopefully they'll get better with the surgery. I'm going to call her EBL 8 mil. Dr. Patel did right side,
He did the
RFA.
right side RFA, frequency of the L344551.
You don't need to say that. You just say L3 to S1,
Okay.
unless you like talking. All right, very good. So let me see what else we have here. I sign that. We're good to go. I'm going to head back to the conference room and I'll come answer some questions. So start typing away. Good job, everybody.
All right, everyone, thank you for joining us for the post-op Q&A. If you have any questions, please continue to post them in the chat. You can also submit them through the Duke Spine Institute app to be answered real time here. We have Dr. Duke in the room with us. He's ready to answer some questions. And our first one comes from a viewer on Periscope who asks, do discs that rub together cause pain? My doctor told me that my degenerated discs are the source of my back pain. How do you treat that?
All right, this is Dr. Duke Majan here, and basically, it's a very good question. So, let me start by saying that when I was done with my training at the University of Florida in neurosurgery, where I trained for 7 years, and every day dealing with patients with disc problems, I was actually taught the same thing, that when you don't have a disc left and you have bone on bone, it's that bone on bone rubbing that causes back pain. I didn't know any better. That's what I was taught by, I felt, some of the best neurosurgeons in the world, which they were, by the way. But it was incorrect. It was 100% incorrect. But I didn't know that coming out of my training. So what I can tell you is this. Pretty much every spine surgeon I know that's a good spine surgeon, well trained, good technique, they all believe the same thing. Bone on bone rubbing causes back pain, but it's not true. What I discovered by doing endoscopic surgery now for 14 years was that it's not bone on bone rubbing that causes the back pain. And I'm going to tell you why. When I do the Duke laser disc repair, and I've done over 1,000 now, with about 600 of them being lumbar and about 400 plus being cervical. We have lots of patients with bone on bone. I do the annular debridement and I repair the annular tear that's causing the pain, and their pain goes away 100%. I did nothing to stop the bone on bone rubbing in all those hundreds and hundreds and hundreds of patients that have bone on bone rubbing. I did nothing to stop the bone on bone rubbing. All I did was go in with the endoscope and I removed the herniated fragment that was in the foramen and within the annular tear, and I did an annular debridement. That's it. I didn't fuse, I didn't put a spacer, I didn't add any disc material, I didn't add anything. I just removed. So how do you explain their pain going away? They still have bone on bone rubbing, but I didn't stop the rubbing. I didn't put a cushion. I didn't do anything with respect to the rubbing. And the rubbing goes on after surgery. So obviously movement of the two bones is normal, but they shouldn't be on top of each other. What I'm getting at is, folks, it's not the bone on bone or the rubbing that causes back pain and neck pain. It literally is the tear in the back of the disc. And this is what only really I know to be true, because I do these surgeries. It's given me the ability to repair the tear, and when I just repair the tear, the patient's pains go away. So how do you explain that if it isn't the tear? I mean, I figured this out probably about 13, 14 years ago, that right away, I mean, after about 10 patients of doing the surgery, I figured out that it was the annular tear that was the cause of their pain. So yeah, I used to believe the same thing, and I don't fault the surgeons for believing it. And the only reason I ever changed my mind about it was because I started doing these surgeries where I didn't stop the bones from moving. And I'm going to say, prior to that, I used to tell all my patients, your pain's coming from bone on bone rubbing. And the problem was that a lot of people would have back pain and they didn't have bone on their MRI. So it kind of didn't make sense, but that's what I was taught. I believed it. I had no reason not to believe it. And when I was doing a fusion, it would stop the pain. So I figured I stopped the bone on bone rubbing and stopped the pain. But it turned out that that wasn't the case. You know, and years later I realized the truth. And that's why we broadcast these surgeries. We broadcast them so people can learn the truth. There's so much misinformation out there about spine surgery, spine care. And that's why we do these broadcasts. If everyone knew everything about the spine and how to cure back and neck pain, we wouldn't be wasting our time broadcasting, because there would be no need. We'd just be another doctor's office treating patients for the same reason everyone else does. But the fact of the matter is that the rest of the world is wrong in how they believe when they think about back pain and neck pain coming from a herniated disc. It's not from the herniation. It's not from the nerve being pinched. It's not from bone-on-bone rubbing. It is literally 100% from the tear in the annulus fibrosus at the back of the disc, right where the nerve root is, because that part of the disc is innervated by what's called somatic afferent nerve fibers. And somatic afferent nerve fibers travel to a special part of the brain, okay, and that part of the brain is actually on the opposite side of the brain, and it's in the sensory cortex, the primary sensory cortex. They project to the primary sensory cortex where there is a sensory homunculus. The homunculus is a little man living on the brain. That's what the old, neuroanatomists and neurophysiologists figured out, is that there's what's called a somatotopic distribution of those fibers onto your brain, specifically in what's called the postcentral gyrus. The precentral gyrus is your motor homunculus. The postcentral gyrus has the sensory homunculus. So basically, the nerve fibers from the back of that L4-5 disc on the right side transmit to the brain on the left side to a little part on the brain where the spine is. And when somebody has pain signals from the back of the disc at L4-5 or L5S1 or L3-4, you pick, it's basically the back of the disc. Those pain signals transfer to a part of the brain, up the spinal cord, up the nerves, up the spinal cord, onto the brain, and your brain goes, ow, wow, I've got back pain, and you can localize that back pain. So when people talk about back pain as being nonspecific, that's garbage. It's nonsense. They just don't know the areas of the back that cause pain. So they're like, oh, I don't know. Okay, think about your watch, okay? If you have a watch that has, it's not digital, let's just say it's mechanical, right? It's got all those gears and stuff in it, all right? If my watch stops working, you know what I say? My watch stopped working. I don't know why it stopped working. But for a Swiss watchmaker who's an expert, they're going to say, let me tell you why it stops working. And they're going to open it up and they're going to figure out why it stopped working. Oh, the gear is bent or something. The point is, to a non-expert, the watch stopped working or your car stopped working. But to an expert who knows how to run diagnostics properly, it's not just non-specific back pain, it's back pain that comes from a very specific place. And that's what Duke Spine Institute does better than any other place in the entire world. We can figure out where the pain comes from, therefore we can cure it. And that's why we're able to cure people's back and neck pain, is because we're able to figure out where it comes from. Now, the biggest issue for us is not curing pain. The biggest issue for us is getting the insurance companies to pay for it. And unfortunately, this day and age, spine care is expensive. And it costs money to run tests, it costs money to do the surgeries. You saw that stupid wire that I use. It's about, 16 inches long, 18 inches long, skinny little wire, $40. You could feed a family for 2 days with $40. Why are we paying $40 for a piece of metal? It's ridiculous. I don't think I've told you all the story, but when I first opened the surgery center here at Duke Spine, we put television, 40-inch TVs in the operating room so I could see the pictures of the fluoro machine. I could see the endoscopic view really well, because when you buy an endoscopic tower that comes with a camera, the monitor is like 20-inch monitor. So you really can't see very well when you're standing there operating. So I wanted to see everything really good, so I bought high-definition monitors from like Best Buy or something. I think it was Best Buy. Anyway, I got them for $500. $500 for a 72-inch monitor. Put them on the wall in the surgery center. Well, next thing, ACA came through, the Agency for Healthcare Administration. They regulate all hospitals and surgery centers. They come in and they look at the monitor and goes, is this medical certified? I don't know. Well, no, it's not. Okay, you've got to take it down and you got to put up a medical certified monitor. Same thing as the one in Best Buy. But we found medical certified monitors, 72 inch, $10,000 a piece. $10,000 a piece. And I had to put 2 in. So I had $20,000 for 2 television screens. And when you ask the manufacturer rep, what's the difference? He said, well, nothing really. We just inspect it and put a sticker on it. Are you kidding me? $20,000 for 2 television screens in the operating room when I could have spent $1,000? There's $19,000 wasted. So you want to know why there's so much waste? It's because of stupid ass rules that the insurance companies and that who run Medicare that they come up with. They're basically wasting money. And the rest of the world laughs at us. The x-ray machine that I use cost $180,000. It's literally a circuit board with a big plug and a little emitter that emits electrons and a detector plate. It literally costs probably $1,000 to $2,000 to manufacture, and here I am paying $180,000. Why? Because that's what the market will bear. That's what they're used to getting paid, and because they know that we can't buy it anywhere else because of all the regulations and restrictions on it. So you want to know what's driving the cost of healthcare up? It's not doctors and hospitals. It's quite literally the regulatory agencies who are controlled by the insurance companies. They want to limit how many surgery centers are built, because the more surgery centers and hospitals there are, the more they're going to pay out in claims, the less profit they make. So you got to start waking up, everyone. Everything in healthcare is being driven by profit to the insurance companies. If you can't see that yet, then you need to really take a deep look at what's going on. Every single thing that happens, no matter what it is in healthcare, no matter what it is driven by the insurance companies. I'm dead serious. I am a pretty powerful neurosurgeon in the state of Florida, yet I can't get anything to happen. And look what's happening around the entire country. Narcotic medications, opioids, are suddenly bad. Okay, you don't want to know why they're suddenly bad? Because the insurance companies have figured out a ploy, a way to make more profit. Here's how it works. Insurance companies have to pay for patients' prescriptions. They have to pay if a doctor orders narcotics, for example, for a patient in pain. They have to pay for that narcotic. Insurance companies do not have to pay for medical marijuana. Why? Because it's illegal federally. So they actually have, the insurance companies have kept marijuana illegal on a federal level so they don't have to pay for it. So what they've done now is they've said, okay, we're spending billions of dollars a year on patients' narcotic or pain meds that doctors are prescribing. Let's start a campaign against narcotics. Let's make it so that no doctor can prescribe narcotics and no patient can get them, then we don't have to pay for them. And people will use marijuana instead, and we don't have to pay for that because it's federally illegal, and that's our way out. That is exactly what's happening, and the health insurance companies are now profiting billions and billions more every year because of if you're a doctor and you write for a pain pill, you can only write for 5 days. Basically, you'll be persecuted, maybe even thrown in jail. All right? So doctors are scared to death to write for pain pills, narcotic pain pills. So now patients are going out and getting marijuana. Well, guess who pays for the marijuana? You do, patient. Your insurance doesn't. So who's the big winner here? Anyway, a lot going on. Anytime you see something in healthcare, understand why it's happening. It's all driven by profit to the insurance companies. They write all the laws. They do all the marketing. They do all the propaganda. They control the politicians, both local, state, and federal. Anyway, if you want to get something good done in medicine, we have to regain control of healthcare. The people have to regain control of healthcare, and take it away from the insurance companies. What's the question?
There are no others.
No other questions. You guys like hearing me ramble on. All right. Well, this is Dr. Digmajan. Hopefully, I've answered your question appropriately. Did I?
Yes.
And digressed a little bit in a way that you find educational, interesting, and most importantly, I hope you find it inspiring. Inspire yourself to do something good and fight the insurance companies for their bad. Okay. We'll be seeing you all hopefully in 30 minutes for the next case.